Hello and good afternoon, everybody. My name is Dr. Abad Khan, and welcome back to the CRISP TV. We are here in Mumbai, and I'm an interventional cardiologist currently practicing at St. Joseph Hospital, Ghaziabad. Now, today is day 2, and the heat is going to the roofs. That we have exciting topics coming up in the evening hours also, and for the same extension, we have an exciting guest on the CRISP TV, Dr. Rajneesh Kapoor. Welcome, sir.
Hi, thanks Abad.
Dr. Rajneesh is a chairman and interventional cardiologist at Medanta Hospital, Gurgaon. He has been a recipient of numerous awards, including Punjab Ratan, among the many ones he has received already. Sir, you have been the epicenter of structural intervention in India, especially in the northern part, with strong numbers and data for mitral valve interventions and aortic valve interventions. Sir, how have you seen your practice, which has changed, if it has changed, over the aortic valve interventions over the past so many years?
See, definitely structural heart interventions has changed the whole paradigm of cardiac interventions. So, first let's take a aortic valve, which is TAVR, transcatheter aortic valve interventions, which we are doing very frequently now. We started that in 2014. That was the first time it arrived in India. So I still remember in those days we used to take almost 4 to 5 hours to do one TAVR. It was under general anesthesia, and then groin access was a big issue. So over the time, the hardware has modified, the valves have become much patient friendly. So our the vascular closure devices are there. So now hardly we take 40 minutes to do a TAVR, and we release the patient. Patient is discharged the very next day. No general anesthesia, patient is in conscious sedation, and many of the patients are actually awake, like we do angioplasty. So it has definitely made a big impact in aortic valve treatment, aortic stenosis treatment, I would say. So in elderly patients now it's a common practice if the patient is more than 70-year-old presenting with critical aortic stenosis. We discuss TAVR with each and every patient. Still, there are some patients because of financial reasons they may not actually plan TAVR, but there are many patients who are now opting for TAVR, and it's a very patient-friendly treatment, very operator-friendly treatment. Both, I would say, the pacemaker rates have gone down. The technique of TAVR, the valve deployment has further improvised, and you know there are hardly complication rates, vascular or anything is less than 1%. So it has revolutionized this area, that aortic stenosis patients who were very sick prior or even now in the moderate to low risk beyond 70 is it's a big thing. Patients are I would say very lucky because this procedure is there. We can actually salvage. We have saved many patients who were very sick with TAVR where surgery was not possible at all. So it has made a big impact in this area. Now let's talk of a mitral valve intervention. So this is also interesting that we have a M-TEER, which is called transcatheter edge-to-edge repair. Mitra clip is there, which is again a treatment for severe mitral regurgitation patients. And you would agree, being a cardiologist yourself, that the loop, the pool of these patients is very huge.
Yes.
And now these patients are also very sick. Now, severe MR patient with LV dysfunction is not going to do good with surgical intervention. So these patients are also, I think this therapy is very good for such kind of patients, these subset of patients, where the surgical intervention is very clumsy or very risky in such patients. Again, this also we are doing now quite frequently. So initially I would say it requires some time to make up your reflexes for the operators also, for the system also, for the hospital also. You have to have teamworks, in place. It's not a one operator procedure, it is a 2 or 3 operator procedures. But I think it's very good modality for patients, and uh, we can actually save more and more patients with these modalities.
Perfectly placed, sir. Who else and better to speak upon this future of these interventions as Dr. Rajneesh Kapoor. Sir, now with the own India-made mitral valve intervention devices available, which have competed in the head-to-head trials against the devices which are already available way before my valve became the thing of India. Now for severe mitral regurgitation also, MyClip is available, and many more devices are to come up in the next couple of years. Do you feel finally that we would be able to offer affordable care for our Indian patients for the subsets, maybe let's say in 5 years or in 10, 5, 6 years?
I think this is a very good thing happening for India, that these now devices are indigenously manufactured in India. First, the MyValve, the company which is actually making a breakthrough up till now is Merrill. There are other companies also pitching in, but yes, they are still uh, trying to find a good place for them. Hydra is one, but Merrill with MyValve and MyClip uh, has made a space for itself, and I would say this is a very welcome step for India regarding the affordability. See, India, the numbers in India, we are still lagging because of the cost issues. So these are very costly treatments, and if we can have uh, some device which is 20-30% or for 40% giving a lesser cost as compared to the US devices, I think this is a big thing for India. I would further be very optimistic that cost is going to come down with more and more Indian devices coming up, and I'm very uh, this is actually a proud moment to say that it's very good to see that Indian manufacturers are also jumping into this field and making a good substantial products which are almost at par with the Western products. We are very comfortable with MyValve. We are very comfortable with MyClip. I have done around 10-15 MyClips already, and it has, see, once we are using Mitra Clip, which is Abbott US product, the cost was almost 33 lakhs for one Mitra Clip. Now it has suddenly come down to 23 lakhs. So these things make a big difference, and I'm quite optimistic that in times to come, in the next 1 or 2 years, it will be less than 15 lakhs.
Perfectly placed, sir. Sir is optimistic and very proud, as we all should, Indians should be, that the interventions and the development in Indian, the players, the people, and the engineers from the Merrill team as well as the other companies are making a huge progress and making treatment affordable for Indian patients. So where does tricuspid, the TV tier, fit in as per the current available devices and the patient population? And what's is the usage and what's your institutional data on the same with respect to outcomes also, sir?
So yes, now tricuspid valve is usually we say is a
Forgotten.
forgotten valve, but then we know as cardiologists that it has huge implications when somebody has a severe tricuspid regurgitation with which is leading to RV dysfunctions. The patient is very vulnerable with these tricuspid regurg with RV dysfunctions. The natural history goes down dramatically. Mortality figures are also higher. So there is again a big pool of patients who require a tricuspid valve repair. So we are doing tricuspid valve clipping already. We have done almost 50 cases or so, and initial results look very promising, and we can actually change the natural history of many such patients. We had salvaged many such patients who were actually admitting to the hospital with repeated heart failures, but then after a good effective triclip, they are not having any further heart failure events. So it is going to change the natural history of this tricuspid valve disease. It is more intricate procedure, more technical procedure. It requires more expertise, more teamwork. The T guy who's actually directing you has to be very astute, very intelligent, very promising, I would say. The images should be very good. So again, it can only be done at institutions initially with a good expertise. We are lucky that we are doing that, and I think the avenue is going to open further slowly and gradually. But yes, it is very promising. US is actually seeing and going through a lot of tricuspid valve replacements where they are replacing the valve percutaneously. Now that modality is also going to come in India in next 1 year or so, although the cost again would be high. So I think India is all there providing all these kinds of intricate and difficult procedures to our patients, although numbers are lesser because of the cost issues. Now that's where we need to look at that how we can decrease the cost. One thing which is happening good Abad, I would say, is that now of late last 1 year or so, there are many PSUs, there are many government undertakings who have started reimbursing these procedures. This is very good. The numbers have really grown after that. So I would urge that government should have more policies where they can reimburse these patients also, genuine patients who require these procedures to save their life.
Absolutely, this is what we are aiming for. This is what the big institutions and big the people who have expertise in are aiming for. That we should be able to improve the quality of life. And as sir says, maybe alter the natural history of disease, which he is able to do it with for the tricuspid intervention. And it's a damn hard thing to do. We all know that. We all interventional cardiologists know that. Sir, things have rapidly evolved in India in structural heart interventions as well as the complex high risk coronary interventions, but obviously not at the same pace at the West. What advice would you give to the interventional cardiologists who wish to pursue structural cardiology or chip interventions in India? Because till the time as we speak, there are no fellowships available to learn these dedicated structural cardiac interventions, sir.
So no, I think see the institutions where the numbers are higher, the operators, who are doing better volumes or good volumes with structural heart interventions, we are leaving no stone unturned to replicate or to disseminate these procedures to other hospitals. So there are two ways where we are actually doing our effort to disseminate these procedures down the line. One, we are proctoring wherever we get a call. So wherever there is a patient, we go to their centers to do these procedures. This is one way that we actually make other cardiologists learn about this procedure. Second, we are also calling many young doctors, many young cardiologists to our setup whenever we have we actually club few cases in 2 days. This is called a workshop. There is no structured fellowship, but we are doing many numerous workshops in this area. So like a 2-day workshop where 5 TAVRs are planned or 1 or 2 mitra clips are planned. So then we call about 10 guys to our center, and they learn all the steps, they see the procedure, they see the nuances of the procedure, and that is where they feel more confident and learn many more things about that. This is the best way to initiate the things like that. But I think as we grow further in volume, there will be more fellowship programs also coming up. But yes, we are absolutely open. What I can say, at our center, we have a good volume of these structural heart intervention. We are absolutely open if somebody wants any kind of support or help in this area, and there are workshops which we are already planning.
So perfect, and this is Dr. Rajneesh Kapoor sir speaking. That to all the viewers and all the interventional cardiologists, budding cardiologists who wish to seek and take help for structural heart interventions, Medanta and with Dr. Rajneesh Kapoor sir is the way to go. And it is a learning process. You can call sir as well as his team members to your place, or maybe go and just pay him a visit and just observe the procedure, sir. Sir, how have you been liking this CRISP conference, and what is the idea for attending such conference as big as this should be?
No, I think I'm very happy with the kind of the, you know the program and the conference that has been projected, or you have organized this great compliments to Ankur and all the team who's behind this. So it's a wonderful, fabulous program, and this is the way that people can assemble at one place and learn a lot of things in 2 days. Whether it's a chip intervention, whether it's a nightmare in cath labs where people have problems. See, we actually learn maximum from the problems or the nightmares which happen in the cath lab. Once we start sharing that, you require audacity to share that. But once we start sharing that, I think there are many learnings in that case discussions. So pretty happy with the kind of program which CRISP organizers have made. And as I previously also pointed out, as the name goes, CRISP. So this revolves around many crisp cardiology topics, and that's the best thing. And people who are attending, I think at end of the day they will be learning lot many things, and it will be very productive and very enriching to all the people who are attending this conference.
Thank you so much, sir, and thank you for saving some time for us and be on the podcast. Thank you, sir, and see you on the next podcast.
Thank you, Abad.